Hello, everybody there in social media land. My name is Danielle Dion, and I'm here with No Violence for Kids Canada. And we are working to raise public awareness for Call to Action 6 to repeal Section 43. And in doing this, we're taking some initiative to have deep conversations and interviewing folks that are in the conversation more and that can help us understand why maybe this is still happening in Canada, why corporal punishment is still happening, and also to urge everybody to have conversations around Call to Action 6 to repeal Section 43. I'm here in my home, which is on the treaty territory of the Tsawwassen Nation, which is home of the Semiahmoo people, otherwise known as Surrey, British Columbia. And I'm also here with Dr. Robert Maunder, the author of the brand new book. I guess it came out a couple months ago, Damaged. And this is a book, a call for a revolution in care. Dr. Maunder is a part of a team of two with his co-worker, John Hunter, Dr. John Hunter, and the two of them work out of Mount Sinai Hospital as psychiatrists over there. Dr. Maunder is also a principal investigator of studying the impact of close interpersonal relationships, so attachment relationships, on stress and the course of medical illness in ulcerative colitis and heart failure. He's also done extensive research on stress and resilience for healthcare workers, and is also a professor in the Department of Psychiatry at the University of Toronto and chair of health and behavior at the Sinai Health System. And I'm sure I could go on for many more days looking at publications and credentials. One other one that I just wanted to mention is the Deputy Psychiatrist in Chief and Head of Research for the Department of Psychiatry at Mount Sinai Hospital in Toronto as well. And like I said, the co-author with Dr. John Hunter of the book Damaged, which is hitting #1 charts out there. So, and no doubt about it, it is fantastic. I've been reading it on my Kindle. I was just saying I'll likely be buying a hard copy. It's literally one of the best books I've ever read. So just to get started, before I always start these interviews, I always start with a quote. Anyone who does anything to help a child in his life is a hero of mine. And that's by Fred Rogers. So welcome this hero to our interview today. This is Dr. Robert Maunder. Hello.
Hello. Thank you so much for having me.
You're so welcome. Let's start out. I'm so interested how you got into this career, this work.
Well, the work I do is the psychiatry with people who have medical and surgical disease. So I'm kind of in a subspecialty of psychiatry, and I kind of backed into this, to tell you the truth. I wasn't hell-bent on going to medical school when I got into university. And when I got into medicine, I had no idea that I wanted to do psychiatry. And when I got into psychiatry, I didn't really realize that psychotherapy would be of interest to me or that I'd be any good at it. And I was graduated and practicing for more years than I'd like to admit before I realized that most of my patients were telling me about trauma, and I wasn't really hearing it.
So the trauma kind of kept you going. So it seems like you were surprised all along. You just followed an interest.
Yeah, I in retrospect, I kind of think like I was born to do this, but it wasn't. It wasn't planful. I just did the things that I was interested in, and hopefully the things that I was good at, and it kind of led me where it led me.
And I have to just say, this is an interesting answer, because when I asked this question to the professionals that I've been interviewing, and they're successful with the incredible bios, it's the same sort of thing. I was leaning into what I was interested in, and I just kept being interested in this, and it led me to this calling. And in reading your book, Dr. Maunder, I would absolutely agree. I'm so happy you are doing the work you do. And I'm not only happy you're doing the work, but I'm happy you're writing about it. It really does shine a light on your skill, your book does, and also your compassion and knowledge of the field of healthcare. I'm not in the direct field, and I've never been in that community, but through reading the book, I got a real sense of what that might be like and what the conflicts might be like. If we were going to just to do a quick summary, we're here to look at Damaged. Can you tell me what Damaged is about?
Sure. And let me say before I start, if you're comfortable with it, please call me Bob.
Okay.
Damaged is, in the first place, it's a story of a man who we call Isaac, and who I've been seeing in psychotherapy for over 20 years. And so it's the story of his life and the story of our relationship through that time. And the story as well of my relationship with John Hunter, who's a colleague and a friend. We went to medical school together. We go back a long way as well. Who does the same sort of psychiatry that I do, right? And so we kind of share that work and talk to each other and help each other out with it. So it's that story, and then throughout that story, we use that to teach and talk about. I got a cat walking beside me. Sorry. To teach and talk about childhood trauma and how astonishingly common it is, and the impact that it has on people's lives, their mental health and their physical health throughout their whole life, and on the next generation and on the next generation, and how invisible that is in most medical conversations.
I think you just nailed a big piece of the book that I took away too, was that I was a little bit surprised when it kind of came to, like, you're working in the surgical piece of psychiatry. So you're seeing patients with heart problems and colitis and Crohn's and trauma, like childhood trauma. So tell me more about this connection, because I think it's surprising to hear that piece of the healthcare industry needs to address childhood trauma. Why?
Well, I guess that's one of the reasons. I mean, that's a question is one of the reasons why it took me a while to realize that had such an important place in the lives of my patients and needed to be part of our conversation. In retrospect, it's obvious, because childhood trauma, especially when it's severe, especially when people have lots of different kinds of it, we call it a cause of causes of health problems, right? So because it has an impact on physiology, and it has an impact on behavior, and it has an impact on relationships, and it has an impact on how well you can explain yourself to healthcare workers, right? It has this kind of cascading effect on health. The result of that is that people with that experience are much more likely to find themselves on a surgical ward or on a medical ward, because it's a risk factor for those physical illnesses, and it's a risk factor for mental health problems. So if you're a psychiatrist seeing people on medical and surgical wards who benefit from speaking to a psychiatrist, it just stands to reason that a substantial portion of them are going to have experienced that. And oftentimes, I would say most of the time, have not particularly made a link for themselves that there's any relationship between their heart disease or their their chronic infection with hepatitis or whatever it is, have not made the link between that and what happened to them when they were kids.
That's, I think, the important piece too, that people might not know. So they end up in the hospital with heart problems, and then they speak to a psychiatrist, and you're able to help them understand that a little bit, or
sometimes everybody's different, right? So it depends on the circumstances, but at the very least, you can hopefully help people react to current circumstances in the way that's best for the current circumstances, rather than just kind of hitting on the reflexes that they've learned through bad experiences in the past, which is often when the psychiatrist gets called, because the doctors and the patients can't get along with one another. It's kind of like an interpersonal problem. And then you realize that neither one of them's actually hearing the other very well. And that oftentimes those kind of communication problems harken back to trouble we're talking about in the patient's life. But like, the healthcare workers are not immune from having traumatic upbringings either, right? So it's like they're complicated interactions.
Very complex for sure. And I really like what I'm hearing you say too, is when we're dealing with early childhood trauma, you mention a lot about the ACEs score in your book. And I also noticed if you go to the www.maunderings.ca, that you actually have a link on there to check your ACEs score. And so can you talk a little bit briefly about more what ACEs are and how does that inform your work?
Yeah, so I'll give you a little bit of a spiel. So I'll try and be coherent, because it has a history. And
Sure.
ACEs are like really helpful, but it's also helpful to know the history, because they're not people make more of ACEs than is useful sometimes, but they have a value. So the idea of ACEs stands for Adverse Childhood Experiences. So it's just like a useful acronym, and that label for difficult experiences in childhood goes back 20 years or so now, and it was invented as a research tool. Really, it wasn't invented as a way for people to understand themselves. It's a way to very quickly assess the amount of adversity that adults, you ask adults, but what they experienced when they were kids. And so it just quickly checks out in the original form 10 different kinds of adversity and adds up how many happened for you, right? So physical abuse, sexual abuse, emotional abuse, neglect, having a parent in jail, having a parent with a mental health problem, having a parent with addiction, losing a parent when you're young. I'll always leave out one or two, but it identified 10 things and just gave people a score for how many they were able to check off. And that was powerful as a research tool, because it allowed those researchers, that was Vincent Folletti and a group that were down in San Diego, to find that there was a link, a pretty strong link, between how high your ACE score was and how high your risk was for most of the physical illnesses that are reducing quality of life and reducing the length of life. So most of the chronic illnesses that are familiar to people, the higher the ACE score, the higher the risk. And so that was like the kind of beginning of the modern history of understanding the role of childhood adversity in physical disease. And because it's a really good acronym, and because it's such a simple method of assessing childhood adversity, it kind of caught on in other circles. And so we use it as a teaching tool, so that you can kind of quickly assess, well, where do I stand in that kind of compared to others in terms of childhood adversity, and so it can be helpful as kind of the beginning of a conversation and the beginning of self-reflection on whether that might have some role in what you're experiencing now that you've grown up. The difficulties with it are that those 10 categories are not special, right? I mean, we can't assume that they chose right when they chose 10 categories back in 98 or 99 or whatever it was. And in fact, there are lots of adversities that are important and that there's now good evidence should have and could have been on that list that weren't. So growing up in an unsafe neighborhood and experiencing bullying and experiencing adversity because of your gender identity or your race, there's an expanded list, and there's there'll never be a list of adverse experiences that's the right list, because it actually depends on like how you experienced it, not just exactly what
Right.
happened. So there's nothing magic about ACEs, and it's not the score, right?
Okay.
It's the experience that in
Right.
the end matters. So
Yes.
so ACEs, I think, are like a really important idea, but they're kind of a doorway into
Mm-hmm.
conversations and to understanding. Um, and so we put an ACE calculator on our website so that people could understand kind of how they would score in that
Yeah.
original measure. But if you've got a 5, or if you've got a 6, or if you've got a 7, it's just a kind of a place to start, right?
For sure. And I guess the other side of going through adversity as a child is also looking at the protective factors too around. Do you have supportive family around you, community connections? Do you have examples of strong relationships? So I guess that list too could be pretty infinite by how a child might perceive that experience, or even adults when they look back.
Yeah,
Yeah. So that makes
totally.
it
Like some
not
people have
complex.
terrible experiences as kids and actually get through it pretty well, right? For
Hmm.
exactly the sorts of reasons that you're describing there.
Yeah. And I like to, when I'm reading the book, what I'm noticing is the conversations that you're having in the book about ACEs, but it's also to inform your work. So it's offering a lens of compassion and understanding. And I think that's such an important piece to this revolution in care, is that it's a greater opportunity to understand and create understanding, but also this platform and theme that I'm hearing about storytelling. Can you connect more about that? And I think our listeners really could benefit from hearing how important storytelling is from a healthcare perspective.
Yeah, so I can sort of talk about that in two different ways. So I need to keep them in sequence, or I'll sound incoherent myself. Uh, so one way to approach that is just to think of what happens when you have a health problem and you seek help for it the first time, right? And
Mm-hmm.
it's helpful to imagine that it's something that feels like it might be serious. So imagine something that would bring you to the emergency department, right? And you don't know if it's serious or not, but you think it is, right? So you're scared and you're uncertain, and you're meeting a stranger, right, who may be intimidating, and you don't have much time. And your task is to explain yourself to this person so that you can get some answers and get some help. And that means you have to tell a story to an
Mm-hmm.
audience of one, and it's the story of you, right? And you can't
Mm-hmm.
tell the whole story of you. You need to tell the story of you that gives this person what they need to be useful to you. So
Mm-hmm.
it's a storytelling task that requires a great deal of skill. So, and we're not all skilled at doing that. Um, and healthcare providers, doctor in the emergency department in this case, are not particularly trained in the skill of helping you to tell a story. They often are thinking of themselves as information
Right.
collectors and decision makers, right? And so if you in those circumstances are not very good at telling your story, which wouldn't be too surprising because you're scared and you don't know what's going on, um, uh, then you may come across as like what we call a difficult historian, right? So
Mm-hmm.
your communication might be seen as
Mm-hmm.
problematic and inconvenient, right? So uh, that's a situation where the healthcare system, just because of the way it's evolved, is biased towards a good storyteller, right? If you can tell the story
Mm-hmm.
of you in a way that appreciates your audience and gives them what they need so that they can kind of
Yeah.
collaborate with you,
You'll have better
then you're
care.
way ahead.
Yeah. Mm-hmm.
Um, so, and that's all kind of in the background, right? It's that nobody's
Mm-hmm.
explicitly thinking about being a
Mm-hmm.
storyteller when they walk into an emergency department, and neither is
Sure.
anybody on the other side of the conversation. But that's a way to understand what's going on. And relevant to our conversation, having experienced trauma just plays havoc with storytelling skills. So like in psychotherapy work, which is what we're writing about, it's not actually what we're writing about in the book. It's the scaffold by which we can talk about all this other
Yeah.
stuff in the book. But psychotherapy work is kind of collaborating with somebody to help them become a better storyteller of themselves.
Mm-hmm. And that resonated. So the work really in healthcare, part of the revolution that is encouraging the skill of asking for help and telling your story in a way so that you can get better care ultimately. And so that you're not kind of put in this difficult box, so that you're understood from your lens. And then there was this other piece of, oh, go ahead.
Well, yeah. So I was going to say that's exactly right. Kind of on the patient side of that relationship,
Mm-hmm.
and on the provider side, like our basic goal right now is to try and encourage healthcare providers who are not in mental health, right? So the whole rest of medicine, to ask, right? Just to ask about trauma and adversity.
Mm-hmm.
And the one of the most common responses we get back from that is, well, what am I going to do with the information, right? How is that going to help? And to which we respond, well, it's not actually about the information, right? The information might be helpful, but you ask people if they've got a family history of heart disease, right? And that you ask people if they have a family history of cancer, and it's all in the past. You can't change any of it. You're not using that information to change treatment. You're using that information to understand what's going on, right? It's helpful to have context. And more importantly, for the storytelling part, if you ask, you will have conveyed to somebody, I'm talking to somebody who's interested in me. Like they want to know about me. This might be a safe place to have a conversation. And that's powerful. Like that's way more powerful than the knowing that their ACE score is 3 or 4 or 10 or 0, right?
Absolutely, it's powerful. I think it was Brene Brown that said, shame can't live when we tell our story, right? When it's out in the open, something along those lines. It's great impact and a wonderful thought to hear that you're encouraging this. And I noticed on Twitter today, there was conversation going about that, that heroic work by saying, just let's pause and listen to story. It doesn't have to have, a meaning in what decision we're going to make. Right? Just in asking is precious, and creating a safe space that maybe people haven't felt from a system before. So important. Part of the work at No Violence for Kids Canada, part of the work, the big work, but what we're looking at is physical discipline. So here I am, talking to a psychiatrist who works in surgical care, and I'm like I study social justice and from parenting kind of liberation lens, and as an advocate to urge our government to repeal Section 43, I'm interested in linking your work to physical discipline. So tell me more about how, because I noticed there's an excerpt in your book, you do talk about corporal punishment and the legislation around that. Can you talk a bit from your lens there?
Yeah. So I've always got more than one thing to say, so I'll try and organize myself. So one of the things that we talk about early in the book were some reactions from the public to media coverage that Dr. Tracy Afifi's work got, and she's done. You're nodding, so you know her and her work. She's done a lot of really excellent work, really good, robust science, kind of demonstrating that just how common serious adversity is in childhood and how that's linked to a whole range of adult health outcomes. And this study in particular was done in the military, right? And this is a few years old. They just actually published a 16 or 18 year follow-up of this work. It's really, really important work. And one of the things that it showed, if I'm remembering the statistic right, was that the prevalence of serious physical or sexual abuse or witnessing interpersonal violence in the childhoods of those military personnel was around 50%. It's just like an enormous percentage.
Yeah.
It's enormous in everywhere, right? It's around a
Yes.
third in the
Yeah.
in the world at large, but it's even higher there. It was 50%. And the reading through the comments on the CBC website story about that, there was a lot of pushback about you must have been saying anything was abuse to get up to 50% abuse, and my parents spanked me and I turned out fine, and those kinds of comments. And one of the people who left a comment that we quote in the book because it was so striking, that when I was raised on the military bases, and I have memories of like my father grabbing me by the throat and holding me up against the wall, and I never thought of it as trauma. I just rationalized it in my mind that was like normal. And so I raised that to just kind of draw out a spectrum of physical discipline and physical abuse in households, right? So there's a kid who gets spanked for discipline, and there's somebody held up against the wall by their throat, and there is no doubt that those are different events, right? So I use that as preface because I want to talk about spanking, just spanking, being bad for kids, right? That there's, and again, I'm relying once again on Tracy Afifi's work, right? But there's no evidence that that's helpful, right? There's zero evidence that helps with the behavior that is trying to be corrected or leads to any good outcomes for kids, right? The amount of good that does is zero. And there's lots of evidence that it raises the risk for downstream problems, mental health problems, and a whole range of problems. And that's at the low severity end of physical abuse, right? So I don't want to pretend that those two events are the same, but I do want to say that even the one that's like just spanking, that like people of my generation are unlikely to have grown up without being spanked, that it's harmful and it's not helpful, right? And that's the behavior that we have like a carefully thought out exception for in the criminal code, in our assault laws, right? That assault is assault unless it's hitting a kid for discipline, right? And then it's not.
Then it's not. We assault a dog or even, anybody else or any other living thing in Canada. It's a living person, human, animal. Everything can be assaulted. Everything cannot be assaulted except children. Children are still not protected legally from an assault. And so tie this into your work. Do you hear people talking about this? Do you hear your clients, go back and say, hey, I was spanked? And
well, honestly, mostly to rationalize it and normalize it. Like it's pretty exceptional for somebody to talk about being spanked and to see it anything other than just that's the way things were done back then.
So it's so deeply embedded as normal. And I think that's the part of the apathy that we're seeing in this, trying to raise public awareness, that there's like a normalcy around it. And then people wonder, like, what's going on with kids nowadays? What's going on with parents nowadays? Oh, it's normal to do that. And that is the work, right? So how do we break free from this apathy? I think that your book really speaks to that in such a wonderfully compassionate way. The story of Isaac and the way it's told, the courage to tell the story, all of it, and relating back to trauma. And as you're seeing your work with him and the conversations that you're having, the deliberations that you're making with John, the whole story itself is a piece of advocacy. At the end, to me, it came all the way around to putting the best interest of children at the center of everything. So it really did. I was like, wow, went from surgery to this Isaac person to all these offices. And here it comes back down to, again, to parenting, to caring for kids and putting their best interest and their safety at the forefront of, and it seems to come up in every issue, social issues somewhere, childhood trauma, spanking, this issue of abuse. Let's imagine that Canada did repeal Section 43. Like we know in other countries, it doesn't necessarily immediately change parent behavior. Why did you write about that in the book? Why is that important for Canada to do something like that?
Well, I think it's important for two reasons. One's principled and one's pragmatic, right? The principled reason is there's no justification for that exception to our assault laws, right? Mm-hmm. And if you try and think of what the justification is, the only understanding that I can come to is that there is a tension or a conflict between two values at work there, right? And one of them is parental autonomy to choose to parent as they see fit. And the other is the welfare of children, right? And what that law is I think, expressing is a societal value that if parental autonomy comes in conflict with the welfare of children, we're going to let parental autonomy win that conflict. Mm-hmm. And Canada's behind many other countries, and it's surprising to me when we did the research, many states in the US in allowing that tension to be resolved in favor of autonomy instead of in favor of children's human right to safety. And so in principle, I think it's just really important to make a public statement that the welfare of our children trumps autonomy in that situation where kids are being hurt. So as a matter of principle, I don't think it matters whether it actually changes behavior or not, right? I would rather live in a country that publicly endorses the welfare of children, right? As a kind of more pragmatic, practical matter, I think changing the course of childhood adversity, which, like in my world in healthcare, is not even part of the conversation. It's like invisible, right? But in the world at large is mostly not part of the conversation, right? It is something that people like choose not to see and not to attend to, right? That's a very hard cultural shift to make that first visible and then change it. And it's going to require many changes in many domains, right? And I refer to, like, I think we are now with respect to childhood adversity as we were in the 60s with respect to smoking, right? The evidence is in. Like, we don't need any more evidence. What we need is change. And there was change in levels of smoking and importantly, kind of public attitudes towards smoking as a result of that. But it took about 25 years, right? And what was happening over those 25 years were changes in legislation, changes in pricing, changes in how smoking was conveyed in movies, right? And in television shows, removing advertising, putting boring packaging on cigarette cartons. There's like a whole host of things. And it took all of that to actually shift cultural, societal values. And I think there's a similar kind of challenge with addressing childhood adversity and a public statement that assault is assault and it's still assault if you're hitting a kid for discipline is an important part of that, whether it changes behavior or not.
Absolutely. I appreciate what you said. Assault is assault. And kids should be at the forefront of that and protected most of all. And apparently, and the truth is, it's least of all in Canada and many other countries, like you noted. And we are behind. We are a pathway country that has really signed on to the Declaration of Children's Rights, yet still, way behind the rest of the world in banning corporal punishment. We're actually failing at this from a global sense in Canada, and it's really, really shocking to hear that it's really hard to get public awareness about this. And it's really hard to get advocates about this and get people angry about this because, like you said, in your field, you see the research, you read it, it's common. And I think most people just are like, oh, no shit, we don't hit kids. There's a lot of, that going on that they just know it's not right. Just like we mentioned about seatbelts, right? You'd never see a child not wearing a seatbelt in a car anymore. So it's important that we talk about these things and we make sure. And then you mentioned this idea about I heard a little bit of a thread around, well, it's just a spanking. And it brought up for me a part of the book where you talked about that a great parent is a good enough parent. When I read this, I know in my field as a parenting interventionist and conflict mediator, I'm constantly talking to parents saying about their guilt, right? That there's the hardest part about being a parent is being human. And so reading this in the book, I just felt so relieved. This message is so good. So tell me more. What is a good enough parent, Bob?
Well, so the idea of a good enough parent is that you don't, for sure, that you don't have to be perfect, and that you don't even have to be all that good all of the time, right?
Yeah.
You have to be pretty good a lot of the time, as well as having those special moments, and you'll be forgiven for your lapses if they're not too egregious, right?
Yeah.
And the you want to think about all of the parenting work that you do, right? And which is, and a lot of the time it's work, right? And the like most important parts of parenting for like encouraging the kind of security and resilience that we're talking about here are about being responsive, right? So it's about being attuned to having some sense of what's going on with your kids, not a magic sense, right? Just like curiosity and attention, right? So that you can make good guesses about what's going on with your kids some of the time, and then responding like in a way that's appropriate and helpful, like doing like what they're hoping that you'll do in that moment. And then think of how many times you're like too tired and too distracted and too wrapped up in your own trouble to be like as perfectly responsive as you'd really like to, right? You don't get to have your really good moments all the time, and it's okay, right? I think I'm not a parenting expert, so don't let me get too far with this, but I think the impression that we leave with our kids, it has a lot to do with the way we usually are, not the way we always are. And some exceptional moments, right? And you want the good exceptional moments to at least balance out the bad exceptional moments, right? But it's like our great fear writing a book like this is that parents will read this and think, oh my God, I've screwed up my kids. Right? Which is probably a sign of being a good parent, that's what you're worried about in that moment, right?
Yeah.
And so that the idea of good enough parenting is kind of a safety net for that kind of worry, right? It's not permission to be however we want, right? But it's a bit of a release for just allowing good normal human beings to be their best and be okay with themselves.
I like what you said, and just being, and it's about being what you usually are. That's what your kids are going to take away. It's not those one moments, as long as the safety piece is all in line, right? But, we all lose it sometimes. We all get frustrated. And a lot of situations in parenting are frustrating. So having your kids, experience your frustration with you for a minute isn't so bad either. And just who you usually are is so important. I really resonate with that. And the book does such a great job breaking down the role through the this revolution of care. So it's a call for that. But I see in the book, it's pretty structured at the end. Both you and John must have really thought it out for healthcare workers, for parents, for patients. Really does a good job so that it gives everybody an active role in the revolution. And I also see that you've got a couple pages, quite a list of ideas to the revolution as well. There's a lot of points to take away, and each one of them has so much meaning. When you were writing all of this out, I'm imagining it must have taken a long time, because at the same time, you're weaving in this beautiful story of your work with Isaac. And so it becomes so real when you're watching the story. Now that you've finished the book, and it's such a vulnerable piece, are you thinking about continuing this kind of theme? Is there going to be a next book?
Well, I don't know if there's going to be a next book about this or not. For sure, we're intent on continuing the theme. There, uh, uh, you also have to do what you're good at, right? So like I suspect when the revolution's in full sway, we'll do better with people like you at the front of the revolutionary pack than with guys like me who essentially sit in an office having one-on-one conversations. Like that's my forte, right? And like John and I, we're embedded in a system, right? So I think where we can individually make the greatest impact right now is in helping our colleagues to shift their practice towards being more trauma informed. And so I'm would like to, what's the expression? The bumper sticker expression. Think global, act local.
There you go. It's grassroots for you. Yeah, there you go.
If we could bring our own organization towards trauma informed care, that would feel like a great accomplishment, right? And the idea of the book is like the message that we try and convey at the end of that kind of manifesto, at the end of all the things that need to change, is it's actually up to you, right? And there's a role for citizens, as well as parents and patients and healthcare providers and teachers.
I felt that it was a call to action. It was an urgent call saying, hey, everybody's got to come together and has a role to play. And I appreciated that community lens. So just to give you a little bit of space here, I'm hearing your call is locally, but to help the healthcare, I guess, just help colleagues be more trauma informed. If you could come up with two things for all the healthcare workers out there, what would you say would be, the things that you hope they take away?
Yeah, so we get super pragmatic really quickly when we start talking to our colleagues, right? So we've got a video that's on YouTube about how to ask about childhood trauma that's intended for healthcare providers. And the instruction that we got from our colleagues in family medicine who work really closely with us was it's gotta have a mnemonic so we can remember it, and it's got to take less than 5 minutes because otherwise nobody's going to do it, right? So we put together something that is called the CARE method of asking about childhood trauma, and they can do it in less than 5 minutes, right? And the video is almost that short and essentially just says, here's what you have to do and here's why you have to do it, and it's easy, right? And so those are the kinds of tools that we want to use to kind of get in and on the one hand, like help our colleagues in a way that feels useful to them and feels helpful to their parents, That's an interesting
Maybe
slip,
that
to their
too.
patients. Um, uh, but like as a seed of things that are changing, the intent there
Yeah.
is also to stir some shit up, right?
Yeah.
Because like things start to change once you start to move them.
Things start to change when you start to move them. Thank you for that. Absolutely. So I saw the care video. I was looking on your YouTube in my setting up for all this, and it's a really quick little, and it's actually quite fun to watch. So it's really handy. So I recommend anybody who's interested in asking about childhood adversity or having these trauma informed conversations. I'm not straight a healthcare worker, but I took away from that some really great practical tools to have a conversation that might be hard. So yeah, great idea. So go to YouTube, and if you go to the mounderings.ca, there's links to the YouTube, there's links to all of the books that you both have published. You can see the bio. It is such a rich website, and you can really get an idea of how much work and that this is a real passion. So Bob Maunder, you're not doing this just because this is a quick day job here. You're in it to win it and to make change. And so, do you have anything finally that you want to ask, or not ask, but say today?
Well, I just want to thank you for the opportunity. Really, I mean, um, as much as we're advocating for change, we really kind of poured our hearts into this book, which we're anything we can do to kind of spread the word and get people to begin to read it, because most people who begin to read it tell us that they want it to get to the end, and then you'll be part of the revolution.
Absolutely. I 100% agree. I really love this book. And I hope that the people that I love also watch it, and I'll read it, and I'm going to be sharing it for a long time. So thank you for this book. It's touched my heart, and I know it's going to touch my work. And also for today. So answering all these questions, I really appreciate that. And I look forward to more of your work, and you can guarantee we'll be sharing all of that. Thank you so much. Bob Maunder. Everybody go out and get Damaged. I got it on Kindle at Amazon, but I'm going to be getting a hard copy because I know that I want to highlight things, and my Kindle's not good at that. And everybody, thank you for joining us here. And please do go to No Violence for Kids Canada on Facebook. Like, share, and comment. We are working to raise public awareness for Call to Action 6 to repeal Section 43 and it takes everyone to be part of this revolution. Thank you, everybody, and have a great evening.